Hello, my name is John Tsai, and I am one of the nephrologists here at the UCI School of Medicine. Over the next 4 videos, we will delve more deeply into renal physiology, specifically handling of electrolytes and some of the endocrinological features of the kidney. I'll be splitting up the content in several different lectures, but I'll start off by discussing salt and water regulation, along with the importance of the corticomedullary osmotic or concentration gradient in this video. This will be followed by a couple of videos on how our kidneys handle potassium and acids that are generated as metabolic byproducts. Finally, we will wrap up with a video on some of the hormones that our kidney produces and others that affect the renal perfusion along with blood pressure and volume regulation. Recall that our kidneys are integral at performing 3 different functions. The first is electrolyte homeostasis. The second is water balance, and the third is getting rid of excess toxins. While it would be nice if we had a system where we could only get rid of any extra potassium or extra water from the body, it is the third function, getting rid of toxins, that biology has mandated us to filter out all of our serum and then produce a seemingly complicated process to reabsorb all that nutrients that our body needs back through the renal tubules. You can imagine that if we only had a system to actively transport a toxin out of the body, we would never have any capability of getting rid of a toxin that we have never seen in our life and didn't have an active transporter in our kidney to handle. Hence, even though this system is circuitous and complex, it is an incredible system that allows all 3 essential functions through the careful orchestration of pathways through the nephron, and it is these features that makes nephrology such an interesting field. Let's first review the overall nephron before we delve into the nitty-gritty of it all. I'll keep referring to this diagram through the course to map out where things are and what things go where. It gets very complicated quickly, but hopefully with a high-level overview, we can make some sense of this incredible system. First, we start off on the left side where we have glomerular filtration. Almost all our serum is filtered out through this glomerulus, including everything in the serum such as electrolytes or small molecular substances. Everything goes through the filter, and it's up to the remainder of the nephron to reabsorb or pick out certain bits and pieces to make our final urine product, consisting of our waste products and excess electrolytes. In the proximal tubule, remember that most of the sodium that is filtered is reabsorbed here. There are 4 main mechanisms to allow this to occur on the tubular side, including sodium cation transporters, such as the sodium glucose transporter, as seen here on this figure. Sodium is also reabsorbed as a byproduct of bicarbonate reabsorption, which we will be discussing more in depth when we discuss how our kidneys handle acid. Sodium is also reabsorbed as a byproduct of ammonogenesis, with the secretion of ammonia into the lumen, and we will also discuss the importance of ammonia as a buffer in our urine. And finally, sodium is reabsorbed as a byproduct of the excretion of protons when the proximal tubule tries to get rid of excess acid. On the other side, the blood side of the proximal tubule, the sodium-potassium ATPase is integral at ensuring that sodium is returned to the blood, but also at enhancing the electrochemical and diffusion gradients that then allow more sodium to be reabsorbed through the previously mentioned mechanisms. We also have to remember that chloride is also passively absorbed through the paracellular processes, driven mainly by the electrochemical gradient that is created with the active transport of sodium across the luminal membrane. All of these mechanisms, essentially 2/3 of our sodium, 2/3 our chloride, and 2/3 of the water secreted in the glomerulus gets reabsorbed in the proximal tubule. Now let's talk about the other portions of the nephron and the remaining 1/3 of sodium reabsorption. The descending limb of the loop of Henle does not necessarily participate in the movement of sodium, but it is important at reabsorbing water and creating concentrated filtrate. It is also the site of urea secretion, as not only is urea filtered in the glomerulus, but is also secreted in this portion of the nephron, allowing for greater urea secretion. What makes the descending limb important is that removal of water allows a high sodium concentration that sets up the ascending loop of Henle to actively transport sodium molecules out and generate the medullary concentration gradient. Now we arrive at the ascending loop of Henle, which is responsible for reabsorbing about 25% of the filtered sodium load and can be divided into two different segments. In the first, or the thin segment, sodium chloride is passively transported down its concentration gradient. Remember, the descending limb sucked out all of the water but none of the solute, making for a very highly concentrated filtrate. As the concentration of the filtrate decreases into the second or thick portion of the loop, active transport mechanisms are in place to drive even more sodium out. Overall, there are two main effects of the loop of Henle. The first is that we end up with a similar concentration of filtrate entering the loop of Henle, and more importantly, the generation of what is the medullary concentration gradient, or the corticomedullary osmotic gradient. When we talk about water regulation later, this medullary concentration gradient will play a large role in helping provide the osmotic gradient needed to reabsorb free water. We start to get into the fine-tuning of sodium when we enter the distal tubule, but it isn't until we get to the collecting duct segments that hormonal regulation starts to play a key role in sodium regulation. In the distal convoluted tubule, about 5% of the sodium is reabsorbed, mainly through sodium chloride transporter that we see here on the left-hand side of the diagram. Again, the sodium-potassium ATPase remains a key player in setting up the electrochemical gradient that allows for sodium to be reabsorbed. In the last part of the kidney, sodium reabsorption becomes hormonally regulated, primarily through the action of aldosterone. This is where the fine-tuning of sodium reabsorption takes place. Recall from your previous blocks that aldosterone is produced in response to a volume-depleted state or a high potassium state. It is the volume-depleted state that will likely cause us to want to reabsorb and preserve as much sodium as possible, and hence will activate the activity of the ENaC channels to reabsorb as much sodium and subsequently water as possible. If we are in a volume replete state and have too much fluid in our body, our aldosterone production shuts off, leading to a decrease in the ENaC translocation and hence a decrease in sodium reabsorption. We will have more to say about aldosterone in this mechanism when we discuss potassium regulation in the kidney, but know that this is one of the primary mechanisms behind the fine control of sodium homeostasis in our body. Finally, I wanted to discuss water regulation in the cortical collecting duct as the final aspect of sodium handling, given both sodium and water are inextricably linked. Water is essentially reabsorbed with sodium, so the majority of water is reabsorbed in the proximal convoluted tubule and follows essentially the percentages of sodium reabsorption in each area of the kidney aside from the loop of Henle, where we recall that the descending limb is impermeable to solute but permeable to water, whereas the ascending limb is only permeable to solute and not to water. At the last stages of the collecting duct, water excretion is fine-tuned to finally form our urine, and it is at this stage that sodium and water reabsorption are hormonally controlled. Remember, the sodium reabsorption is mediated through the activity of aldosterone, and water reabsorption is mediated through the activity of antidiuretic hormone, or ADH, otherwise known as vasopressin or arginine vasopressin or AVP. They're all the same thing. While the collecting duct is only responsible for reabsorbing 3% of the water, and it doesn't seem like this much, but this can be the difference between peeing out 1 liter of urine and 4 liters of urine, since we filter over 144 liters per day. I'm sure we've all felt the difference between needing to pee once a day versus 5 times a day if we drink too much water. So remember that it is this last portion of the kidney that ultimately determines how much water we excrete and how much we need to maintain, despite it seeming like such an insignificant amount. Let's take a closer look at where ADH acts on the principal cell in the cortical collecting duct. The ADH or AVP molecule attaches to the V2 receptor on the basolateral side of the cell. This stimulates intracellular responses that eventually lead to the production and translocation of the aquaporin 2 channel, or AQP2, that are ultimately responsible for allowing water to quickly enter the cell and be reabsorbed from the filtrate. You can liken the AQP2 or aquaporin 2 channel to a door for the water to enter. But this does not necessarily mean that water will enter. An osmotic gradient must be present to move water, and this is done through the medullary concentration gradient. The formation of the medullary concentration gradient sets the stage to allow a high osmotic gradient for water movement in the cortical collecting duct when the aquaporin channel is open, allowing for reabsorption of water in the presence of high ADH or AVP states. The high ADH or AVP is produced usually in response to high serum osmolality or low blood volume, two states where you would think it's necessary to conserve as much water as possible, hence the term antidiuretic hormone. I wanted to talk briefly about two types of diuretics here, which work on the loop of Henle and the distal convoluted tubule. This will also help us to synthesize what we know so far about sodium and water regulation in the kidney. Loop diuretics are medications that act by blocking the sodium-potassium 2-chloride transporter in the thick ascending limb of the loop of Henle. The diuretic effect is due to the increase in distal sodium delivery, which results in less water reabsorption. Remember, where salt goes, water follows. Thiazide diuretics will block the sodium chloride transporter in the distal tubule, which also results in an increase in distal sodium delivery and less water reabsorption. One key difference is that loop diuretics will eventually disrupt the formation of the medullary concentration gradient by inhibiting the reabsorption of sodium in the ascending loop of Henle, the activity of which is crucial to the development of the medullary concentration gradient. On the other hand, because thiazide diuretics are not affecting the loop of Henle, the medullary concentration gradient remains preserved. Why is this important? This is because it explains one of the major side effects of thiazide diuretics that does not occur with loop diuretics. Water reabsorption is impaired when loop diuretics, but not with thiazide diuretics, which can result in more salt loss but less water loss than expected with thiazide diuretics. In clinical medicine, we look at the sodium concentration in the serum, which is the ratio between the amount of sodium molecules in the body and the amount of water in the body. If the amount of salt and the amount of water losses are roughly the same, then the serum concentration of sodium should not be different. This is similar to the phenomenon that we see at the beginning and the end of the loop of Henle, where at first water is removed, followed by salt removal, to result in a salt concentration that's almost the same despite having removed a bunch of salt and water. However, if we're able to reabsorb water back into the body due to the presence of a very strong medullary concentration gradient, but not salt, then you can see that the sodium concentration will actually tend to fall, with the denominator of water in the body becoming larger, but the numerator of salt becoming smaller. This ultimately leads to our serum sodium concentration being lower, which is what we call hyponatremia. This is unfortunately a very common side effect of this medication that results in many hospitalizations every year, especially in older patients with polypharmacy. Lastly, I'll leave you with a question that relates a medication that we use in nephrology to basic physiologic principles that you have just learned about. What is the effect on water reabsorption of a V2 receptor blocker such as tolvaptan or conivaptan? Will it lead to higher water reabsorption, lower water reabsorption, or will it not affect water reabsorption at all? Pause the video here to think about the physiology, and when you're ready to hear the answer, click play again. The answer to the previous question is that these medications will result in a lower water reabsorption. Since ADH or AVP can no longer attach to the V2 receptor due to the competitive blockade, this results in a lack of production in aquaporin channels. Even though we may have a lot of ADH, we are volume depleted in our system, water cannot be reabsorbed in the distal tubule without the presence of the aquaporin 2 channel on the apical membrane. Hence, this results in water bypassing the absorption process here in the cortical collecting duct and is known as aquaresis. This effect is very helpful in the treatment of volume overloaded patients, especially with low serum sodium concentration levels. Since this medication works at the very last stages of the nephron, sodium reabsorption is not affected at all, and only water is eliminated from the body, resulting in our serum concentration of sodium going up. Now you know one treatment for hyponatremia. Thank you for your attention today on today's mini lecture on sodium and water regulation in the kidney. I have placed a couple of links here with some excellent online resources for you to read and learn more about the pathophysiology of renal sodium and water handling, which will helpfully help to solidify your knowledge. Please join me on the next video as we explore how potassium, another very important electrolyte, is handled in our kidneys.